Can you hear me now? Am I audible to everybody? Yeah? Okay, fine. So let's start. So my first question is about yesterday's class. Who all are there at the class yesterday? Who gave a pterygoid response? And what it is, pterygoid response? Where do you see it? McNamara, what it is? What it is? Anybody, what it is? Exactly. Yes. Very good. Okay, it's a tension zone created because of this stretch in the retrodiscal tissue of the mandible. Okay, got it? When you're trying to bring the mandible forward, the more of the retrodiscal tissue has been stretched. That's what the blood vessels are formed there in particular that region. So then you'll have the pain. The question was on what was pterygoid response. Okay. Yes. My next question is headgear effect. Where do you see headgear effect? Headgear effect. Where do you see headgear effect? Activator Frankel twin block. Okay? Yeah? Okay. Activated Frankel and particularly any wire with a labial wire. Okay? Okay. So today my class is on retention, relapse, left hip palate and surgery, fixed appliance and more appliances. Okay? So lots to cover. So we'll just start up. Okay? So you know that the different schools of thought. The most important thing here, they'll ask you, your MCQ question will be on the names given by different schools. Okay, occlusion school given by Kingsley. He basically believes that you have to maintain a proper occlusion. Okay, you have to maintain a tight contact and proper occlusion to prevent the worsening of any retention. When you're trying to treat a case, you have to maintain the proper occlusion. That was the main concept. Then apical base school by Lundstrom. What he said is, don't try to expand too much the basal bone. What is there, it's natural. When you're trying to expand too much or constrict too much, then you change the most chance of relapse. That's what the basic thing of Lundstrom. Okay. Mandibular incisor position, as you know, given by Tweed. What he told is, the mandibular incisor should be placed upright over the basal bone for better stability. That was his main concept. Okay. And Roger thought that it is basically the musculature. You have to keep a good environment. You should maintain the neutral zone. Otherwise, the musculature will play a main important role in giving a lot of problems with dentition. As you know that, right? Hyperactive mentalis or buccinator activity can cause a lot of problems with the dentition as well as the arch. Okay. So different various schools of retention, and it's very important you should know the names. Occlusion school by Kingsley, apical base school by Lundstrom, mandibular incisor position by Tweed, and muscular school by Roger. Okay. Theorems, sometimes they ask you who gave theorems. It was given by the person by name Riedel. Okay. I'll just explain a little bit points of each theorem. Theorem 1, it says the teeth that are being moved tend to return to their former position. This is basically because of your elastic tissue, your collagen fibers. Okay, like the more they move, the more sooner they can come back. That's why you have to have a retention protocol for at least minimum of 8 months. Okay, what they say is 6 months full-time wear followed by 3 months part-time wear, night-time wear. That is your protocol. 6 months full-time wear of retention followed by 3 months of part-time wear only put in the night time. Okay. And second thing is elimination of the cause. You have to eliminate the etiology. The most important thing, what is the cause? Suppose in case of mouth bleeding, the problem is the there's a blockade. It's a blockade. You should correct the etiology. Otherwise, there's no point. You are not correcting the etiology. You're not trying. You're correcting the maloclusion. It will again reoccur. Getting it? So you should try the correct the etiology. So you should know find what is the problem exactly. What caused the problem is the most important thing. Third thing is overcorrection. Where did you overcorrect? Any example? I told you about overcorrection. Which kind of malocclusion? Again, example. You should overcorrect. Overcorrection, malocclusion. Expansion, very good. Expansion, very good example. Overcorrection. You have to overcorrect. Posterior crossbite. You have to overcorrect. Okay. So that and overcorrect and retain for at least minimum of how many months? Crossbite correction should be retained by how many months? Minimum. 3 months is minimum. Okay. Keep that in mind always. You should at least 3 months. Very good. Okay. And the fourth theorem says proper occlusion is maintained in a correct position. Whatever you are trying to correct, you corrected, you should maintain them. So proper occlusion rate will maintain the occlusal contacts. Okay, that's very important. One more question I want to ask you from yesterday's class is when will you start trimming an functional appliance, a twin block? When will you start trimming? Twin block, 1 week, after 1 week, not after 1 week. Okay, yeah. That is basically for eruption to allow the occlusal eruption. Okay, Aditi, it's basically for occlusal correction. You're giving a functional appliance, meanwhile you're going to try to correct the occlusion. Okay, so you'll trim the twin blocks to allow the molars to erupt. Got it? Theorem 5. The bone adjacent tissue must be allowed to reorganize. This is what I said, reorganize of the peroneal ligament or the bone. So you should give some time for them to reorganize because you have the new position, right? Yeah, okay. Okay. Theorem 6, the lower incisor should be placed upright over the basal bone according to Tweed. Okay. Theorem 7, corrections carried out during growth period are less likely to relapse. Which means you are trying to correct more, right? Trying to advance the mandible or reconstruct the mandible, the bone tends to form there. The bone that formed that period of time, it's much harder. Okay, so there are very less chance of relapse. Theorem 8: farther the teeth have been moved, the less likelihood of relapse. Means overcorrection again. You have to move them more. As I told you, when correcting crossbite, the lingual cusp of the maxillary first molar should be the lingual influence of the mandibular molars. You got it? I explained, right? Everybody, okay? So you should overcorrect it. You should move the teeth far away. So even they relapse, they'll come back to the right place. Okay? Theorem 9, arch form of the mandibular teeth should not be altered. Particularly your intercanine width. It's very important. You should not expand the intercanine width. How much you can expand maximum in the canine region? I gave some protocols. Canine region, how much you can expand? Maximum expansion, 1 mm, very good. Anteriors, anterior, incisors, no? Incisors 1 to 2 mm, keep that in mind. Okay, canine 1 mm, premolar, molar 3 mm, okay, please remember that, okay? Yeah. Theorem 10 says, any treated malocclusion requires permanent retaining device, means sometimes you have to give a permanent retention in some cases, malocclusion, like crowding or space closure, anything, okay? Because of permanent retention. Clear, everybody understood? Different theorems, what are the concept of this? Okay. The different types, self-corrective, self-retentive, like anterior crossbite. See what anterior crossbite, suppose if the upper incisors are lingually placed and you get a proper, you correct the lingual crossbite, it will not come back because the lower incisor acts as a retention for that. Okay, that's why he says anterior crossbite with adequate overbite established but doesn't require retention. Very important from MCQ point of view. Okay. Then short-term retention or limited retention for only for 3 to 6 months. Dentition that are treated by serial extraction procedure because it's normal, but it's a physiological. This is more a physiological serial extraction, so you don't require retention. Highly placed canines treated by extractions. Again, because there is sufficient space for them to come down, it is natural the canines will come down. You don't retain them for any time, okay? Case treated by maxillary retardation after completion of growth period. Okay, again here, maxillary retardation after completion of growth period. Because once you bring the maxilla forward, right, you are trying to get them back. Okay, so there is no chance of going them forward too much. That's why the retention period is very less in those cases, because the bone will get adapted to it. Okay. Correction of blocked out teeth, again, it is something like crossbite. Correction is very, once you get into the, to maintain the occlusion, right? So the treatment, retention plans are very less for this. That is why it's short-term retention. Okay? Medium term, or 1 to 5 years, class 1 non-extraction with protrusion or maxillary spacing. Okay? Class 1 and class 2 extraction cases, deep bite particularly leads retention for a longer period of time. Very important. Deep bite requires for a longer period of time. Rotated teeth also requires, but you should do a procedure called supracrustal fibrotomy. Okay? Supracrustal fibrotomy for rotated teeth. Class 2 division malocclusion. Yeah. Supracrustal fibrotomy. Okay? Permanent and semi-permanent retention, particularly cases treated by expansion, particularly the mandibular arch, that tend to collapse very fast. So you have to give a permanent retention. Generalized spacing which arch length excess. Arch length is more, a tooth size is small, you have to give a permanent retention, otherwise it will tend to open up again. Okay? Severe retention, very important, should be given a permanent retention. Severe labral lingual malposition, severely proclined incisors, you are trying to retract, it tends to go back, so you have to give a permanent fixed retainers. Similarly, midline diastemas, very, very important, you have to give a permanent retention. Cleft palate case, again you are trying to expand the arch, you have to give up permanent retention. Adult patient with a periodontal problem, here you should concentrate particularly the bone loss, okay, because there might be a bone loss, so they tend to change the position of the teeth, okay. So in those cases also should give a permanent retention. Okay? You have different kinds of retainers. Hawley's retainers and the modification. Hawley's retainers, you know that you have a label bow and to advanced class. Modification will be a short label bow, a long label bow. Okay? Fine. Then wraparound retainer is nothing but what will happen, it will cover the entire teeth. Suppose you have a dentition, right? So they will cover the entire arch and they come back. All the teeth. That is called your wraparound retainers. Okay? Canine to canine clip-on retainers, it will cover only the canine to canine. But here the advantage is you will have a label as well as lingual wire. Okay? You will have a label as well as lingual wire on both sides. Label as well as lingual wire. It's called as clip-on retainer. It's called as clip-on retainer. It is a fixed retainer. It is also an active retainer. So it's a removable but it's an active retainer. Okay? It is the active retainer but it's removable. Because it will try to align the teeth. Okay? Clear, everybody following me? I'll come back. See, duration is basically for permanent retention, depends on malocclusion. Usually for what they gave us, at least minimum of 1 year is required. Okay? But lot of other cases like it's like sometimes they give for minimum of 5 to 6 years. Okay? There's no duration. It's a permanent, it's lifelong retention. That's what's called permanent retention. Sometimes you give a longer period of time also. Okay? Another one is tooth positioner. Tooth positioner is nothing but we do the aligner. We spoke about this S6 aligner, right? That Invisalign retainers. Okay, that is called as tooth positioners. Okay? S6, all are examples of what? Removal. Even the functional appliance can be used as a retention appliance. Your FR3 or a class, your Frankel or your activator can also be used as a retainer. All these are examples of removable retainers. Fixed retainers, bonded canine to canine retainers, okay, anti-rotation bands. What they do is they correct the rotation and they place the band attached to the adjacent tooth, so they maintain the position. That's called anti-rotation bands. Band and spur, like a space maintainer, it will be attached to that. And pontic, even if a pontic can be fixed to the tooth, it will maintain the tooth in that particular place, not allow the tooth to move. Okay? All these are examples of fixed retentions. Okay? What they use, they basically used coaxial wire for fixed retention. Coaxial wire or a multi-strand wire for fixed retention. Got it? Clear? Yep. Basically, retention after class 2 correction. First you overcorrect. You can also use headgear or function appliance for the class 2 correction. After, see, what they use basically, whatever appliance is there, they continue to use the same appliance. That is what the concept is. Should continue to use the same appliance so that you will prevent the, suppose you are taking the mandible forward, you should maintain the same appliance for some time till the bone forms. Not lifetime, till the bone forms, till the growth gets complete. See, you are treating a patient at say 8 years. The patient got to complete the growth till 12 years. 2 years you have to give them retention. Then start with the fixed appliance. Getting it? Okay? Yeah. Similarly, for a deep bite, Hollis appliance, the bite plate is given because you have to maintain the bite. Otherwise, deep bite is one of the very difficult malformations to correct, particularly skeletal deep bite. Okay? Open bite correction, you can use hypolate gear, upper molars with a posterior bite blocks. Okay, now I'll tell you why posterior bite blocks are used. Okay, now you have your upper molar and you have your lower molar. You will have a bite block here. Okay, now what happens? The bite blocks will intrude the molars, both upper and lower molars. So which help in the closure of the mandible. So you can correct the open bite. Getting it? That is why bite blocks are used. Got it, everybody? Hypolate gear, the bite block, the posterior bite blocks are used for open bite. For here, we use an anterior bite plane. Always appliance with a anterior bite plate for deep bite. Remember that. Retention or expansion, you can use the same appliance for correction. What they do now, suppose, I'll tell you. This is the expansion appliance. You have an expansion screw like this. Okay, everybody is following me? Yeah, you can continue the same bite blocks. That's what. You have to continue the same bite block. See, this is a retention thing. This is an example of expansion appliance. So what they do is, you have the screw here, opening, where you activate the screw. After expansion, they will just block this hole with an acrylic. Getting it? Which means it will not move back. That's how they maintain the retention using a expansion appliance. They just block the hole where you activate. It is good, no? It is an advantage in open bite case. I will talk about when I am talking about the correction of open bite, okay? See, what do you want in open bite correction? You want anterior to extrude, posterior to intrude. Clear? Yeah, so it's good. What we will trim? What you will trim? No, see, that is different. Your trimming and all is different. You are trying to intrude the posteriors, which means you have to load, you have to keep loading. Okay, you have to load those posteriors, it will intrude. And you allow the anterior to extrude. Okay. You allow the anterior to extrude and posterior to intrude. So you don't have to trim anywhere. I'll talk about this when I'm talking about the treatment of open bite now. Okay, I'll tell you about that. Okay. Yeah. Active retention is basically your fixed retention or a spring retainers where you can bring about tooth movement. Okay, you have a spring placed in the tooth movement. Okay, that is called as active retention. Even your clip-on retainer also can be active retention. Example of active retention. Barrier spring aligner is also example of active retention. Barrier spring aligner. Okay. What happens? Suppose you give a retention appliance, the patient goes back, the patient breaks the retention appliance, the patient comes back with a crowding. Okay, minor crowdings. So that time you can give this aligners. Instead of starting the treatment overall again, you can just use the active retention which can correct the minor crowdings. You can correct only minor crowdings, not too much. Okay. These are the Raleigh-Williams keys of incisor to eliminate lower incisor retention. Okay, lower incisor crowding. Key one is, he basically, lower incisor crowding it basically concentrates lower incisors. He said, the incisor ledge of lower incisor should be placed 1 mm front because there is something called APOG line. When you draw from point A to pogonion, soft tissue pogonion, okay, you have the deepest point A to pogonion. That is a soft tissue point. Okay. So what he said is, you should place them just 1 mm in front, not more than that. If you bring more than whatever, your lip will come into action. That's the first point. And second thing, what he said is, okay, the lower incisor should be spread distal to the crown, which means you have the lower incisor crown and the root. Okay, these two roots should be distally placed. It should not be mesial. So whenever you are doing so that for the better stability, that's what he said. Then, see, the apex lower incisor should be distal to the crown. Okay. All 4 incisors must be in same labial lingual plane. It should be same, it should be aligned properly. Okay. And fifth key is, lower incisor root apex must be positioned slightly buccal to the apex, which means it should be slightly proclined. It should be placed more buccally. And you also said as lower incisor should be slenderized, means you can do a proximal slicing lower incisor to slenderize, to get a good contact. So there are 6 keys, okay. It's just for you to know them, all are based on only lower incisor. If they ask for radial keys, radial theorem is that, see, there are 2 things. This is Raleigh-Williams. These are Raleigh-Williams for retention of lower incisors. Keep that in mind. There are 6 keys. Theorems is different. Don't get confused with the names, okay? Understood? Precision, it is nothing but your supracrustal fibrotomy. As I told you, the teeth tend to come back to the original position, okay? It is particularly because of your transeptal fibers. Very important. You have to cut the transeptal fibers. So the reorganization of periodontal ligament takes at least 3 to 4 months. Please know these dates are these months are duration very important. So the collagen fibers to reorganize takes at least 4 to 6 months. That is why your retention should be done at least for 8 months, minimum 8 months. Okay? And basically your supracrustal fibers takes long time to remodel or reorganize. It takes at least 1 year. So your retention should be at least minimum for 1 year or minimum at least 8 months they should wear it. Okay? And back retainer is also called as circumferential back retainer because what I said told you before, it was given by Begg Okay? You have a label wire running like this, and you have a loop, and it is a continuous arch wire, and it goes back to the maxillary arch. Okay? And the advantage of this is over your Hall's retainer is it doesn't have interdentary wires, so it doesn't open up the spaces, extraction spaces. Advantage of bag retainer is it doesn't have interdentary wire running between premolars, so it will not open up the spaces, and also it helps in getting good occlusion. If you see properly, your Hall's retainer, right, you have a label wire running in between. So what happens when the patient is biting, right? The patient can bite on the wire component, which is avoided here on a bag retainer. Okay, there are no interdentary wires, so occlusion is maintained properly. Keep that in mind. That's the advantage over Hall's retainer. So that's a retention, because nothing but they'll ask retention. Okay, they basically ask theorems. They ask you about this. What are the? See, you should know that functional appliance can also use a retention appliance. Don't think only Hall's retainer or a bag retainer can be used. Even a functional appliance, a headgear, or a posterior bite block. The table what I showed is very, very important. Please go back and read those tables properly. Okay? Got it? Anybody?